cecal polyp. We have already started piecemeal EMR, as you see. Dr. Ammar now will take us through polyp assessment and characterization.
Thank you, Majid. Good morning, everyone. It's Ammar Khair from Cleveland. So this lesion, as Majid said, it's a cecal lesion. It's a Paris 2A. I'm using now BLI. We don't have, unfortunately, zoom magnification here. So this is what we have here, but it's overall high confidence, nice type 2, JNet 2A. So there is no concerns for a high-grade dysplasia or intramucosal carcinoma. And there is it's predominantly granular lesion, no dominant nodule. It's probably about 4 to kind of 5 centimeter. So I think both me and Majid agreed that we can go for piecemeal EMR. Important thing here in the cecum, two things you want to check. The first thing is the involvement of the appendiceal orifice. So we have good space where the appendiceal orifice is not involved. And the second thing, which is also important, the relation to the IC valve. So the IC valve is not here. The IC valve is here on the left. So that's important because we need to plan all of these things before we start. And then the area of gravity is important. So the fluid does not pool. If you have a bleeding, you can still see with the blood pooling away from you. And also when you're resecting that, the specimens go away. So here the gravity, as you can see, is on the left side there. So we started already and we're just waiting for you guys. So we started cutting with including a margin of normal tissue. So we'll continue doing what we're doing.
Yeah, so this is LST granular type, and this is Paris 0-2A, and the risk of covert cancer in this lesion is very low, like 1% or less. This is the typical lesion that could be removed easily and safely with and effectively with piecemeal EMR, high quality, as being demonstrated by Dr. Ammar here. And we are using just saline and methylene blue for submucosal lifting, and we are using a 15 millimeter pulsed encaptivator snare, which is very ideal snare for EMR. And
the needle is not out.
We're wondering with Dr. Ammar whether he will go with hot EMR or cold EMR. And there was an RCT published recently that showed the risk of recurrence with cold EMR around 18% compared to only maybe 1% with the hot EMR arm, but this was expert hand.
Okay. So we'll come back to you guys. I think they're going to go to another room and we'll come and show you what we're doing.
Case of cecal piecemeal EMR. So this lesion, as we just discussed previously, has a very low risk of submucosal invasion, that may be around 0.8%. And Dr. Ammar is continuing doing the piecemeal EMR, going step by step, trying not to leave any small island. And
so Majid, Ammar, I hear you said something about for EMR you use cold snare. Do you do cold snare? And I thought hot snare is better. You said the recurrence is less, but do you use cold snare in EMR?
Thank you, Dr. Hamadi. Yes, I do for increasingly selected flat Paris 2A low risk lesions. But it's important to, when you're selecting the lesion, that the lesion profile is not thick, so you can have a good depth of resection. This one is hard to cut with cold because it's a bit thick, and also it's in the cecum, which we know has a lot of fat tissue. So even transecting with a hot or even with ESD, the dissection or the cutting takes longer.
So I think you want to balance the risk of perforation, bleeding, and with the risk of recurrence. There was a recent RCT that compared cold EMR with hot EMR, and what showed that the risk of recurrence was around 18% in the cold EMR compared to only 1% in the hot EMR group. And there was a single case of perforation in the hot EMR and around 7% risk of bleeding compared to only 1% in the cold EMR group. So I think in a patient at high risk of delayed bleeding with a lesion that has a very low risk of submucosal invasion like this one, maybe you could go with the very meticulous cold EMR technique.
Okay, slowly close, slowly close, slowly close, slowly close, 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 good. So here we're having some difficulty because of the long scope position. So grasping and then checking for mobility, that you have an independent movement of the lumen compared to the rest of the colon, and then we cut through quickly using a EndoCut Q 316. And then once you cut through, just close the snare. You go to the defect and you check that you do not have a deep mural injury and you don't have a residual island that you need to address, and then you check. So here you can see the submucosal vessels. This area here is part of a normal tissue. It's probably not cut because of the area of the snare, but we will remove it anyway. But you can see that we're just continuing to cut through. Open.
So
we have more time, or okay.
Yeah, one minute. I think another point that not to try to use a big snare trying to get more tissue, but that will increase the risk of holding the MP. So in the right colon, typically we don't go beyond 15 millimeter size of a snare. We are using here epinephrine 1 in 100,000 with the submucosal lifting solution to decrease the risk of intra-procedural bleeding. One of the main historical limitation of piecemeal EMR is the recurrence rate that used to be around 15-18%, but now with the thermal ablation of the margin, the risk goes down to around 5 to 1% in an expert hand. So this is a 6 centimeter lesion. We are done in a few minutes.
So yeah, so we just have that part left. So okay. So thank you. So one last thing I will say, that once we finish cutting, what we'll do, and I might just show you a demonstration, just a tip. So we'll do thermal ablation of the margin, just protruding the snare for 1 to 2 millimeter, close a bit, just keep it there. And then what you do, once you clear the neoplasia, you go into the margins and we apply thermal ablation of the margin. Here we're using a soft coag setting, 4.5 if you're using a VIU 3, or if you have the VIU 300, it's soft coagulation 80 watt, effect 4. So you do thermal ablation of the margins. Okay? Okay.
You always do, after clean EMR, you always do thermal ablation of the
Yes, because that shows your reduction of neoplasia down to almost comparable rate of almost an ESD, down to about 3%. In a lot of expert hands, it's actually 0%.
That's the recurrence, you mean, Dr. Ammar?
Recurrence, yeah. Thank you.
Great work.